Heart failure is not simply a weak heart. It is a complex clinical syndrome caused by structural or functional abnormalities of the myocardium. These abnormalities impair the heart's ability to fill properly during diastole or eject blood effectively during systole. As cardiac output falls, systemic tissues receive inadequate perfusion, while elevated filling pressures lead to pulmonary and systemic congestion. Importantly, heart failure is also a progressive neurohormonal disease, characterized by chronic activation of compensatory pathways, such as the sympathetic nervous system and the renin-angiotensin-aldosterone system, which ultimately worsen cardiac remodeling and disease progression. To understand heart failure, we must first review normal cardiac physiology. Cardiac output is determined by stroke volume multiplied by heart rate. Stroke volume itself depends on preload, afterload, and myocardial contractility. Through the Frank-Starling mechanism, increased ventricular filling initially increases stroke volume by stretching myocardial fibers. However, this relationship has limits, and excessive preload eventually becomes harmful. Normal cardiovascular function requires a balanced interaction between myocardial performance, vascular resistance, and intravascular volume status. Heart failure typically begins with an initial cardiac insult, such as myocardial infarction, chronic hypertension, or cardiomyopathy. This reduces cardiac performance and triggers compensatory neurohormonal activation. The sympathetic nervous system increases heart rate and contractility, while activation of the RAS pathway promotes vasoconstriction and sodium retention. Although these responses temporarily maintain perfusion, chronic activation becomes maladaptive. Over time, ventricular dilation, fibrosis, and progressive remodeling develop, leading to worsening systolic and diastolic dysfunction. When cardiac output declines, the body interprets this as inadequate perfusion and activates several compensatory pathways. The sympathetic nervous system increases heart rate and myocardial contractility, while the RAS pathway generates angiotensin II and aldosterone, causing vasoconstriction and fluid retention. Antidiuretic hormone further contributes to water retention. Although initially beneficial, persistent activation increases preload and afterload, promotes myocardial fibrosis, and accelerates ventricular remodeling. This neurohormonal activation is therefore a major therapeutic target in modern heart failure management. In early heart failure, several compensatory mechanisms help preserve cardiac output. Tachycardia maintains perfusion, fluid retention supports preload, and ventricular dilation temporarily improves stroke volume through the Frank-Starling mechanism. However, chronic activation becomes maladaptive. Persistent vasoconstriction increases afterload. Volume overload causes congestion, and progressive remodeling reduces myocardial contractility. Ultimately, these maladaptive responses contribute to continued deterioration of cardiac function. Heart failure is classified according to left ventricular ejection fraction. HFrEF, or heart failure with reduced ejection fraction, is defined by an LVEF of 40% or less and reflects impaired systolic contraction. HFmrEF represents a mid-range phenotype with EF between 41 and 49%, while HFpEF is characterized by preserved ejection fraction of 50% or greater and primarily involves diastolic dysfunction. Although clinical overlap exists among these phenotypes, treatment responses differ significantly, making accurate classification essential. Left-sided heart failure is most commonly caused by ischemic heart disease, hypertension, or valvular abnormalities. Elevated left ventricular pressures lead to pulmonary congestion, causing dyspnea, orthopnea, and pulmonary crackles. Right-sided heart failure may result from left-sided failure, pulmonary hypertension, or right ventricular infarction. It causes systemic venous congestion, manifested by peripheral edema, elevated jugular venous pressure, and hepatic congestion.
Acute heart failure refers to rapid onset or sudden decompensation of symptoms, often triggered by myocardial infarction, infection, arrhythmias, or medication non-adherence. These patients require urgent stabilization and hemodynamic assessment. In contrast, chronic heart failure is a long-term progressive condition, characterized by periods of relative stability interrupted by episodes of worsening congestion. Chronic management focuses on lifelong guideline-directed therapy and prevention of decompensation. The ACC-HHA staging system emphasizes progression of heart failure disease. Stage A includes patients at risk, such as those with hypertension, diabetes, or coronary artery disease, but without structural abnormalities. Stage B involves structural heart disease without symptoms. Stage C includes structural disease with current or prior symptoms, while Stage D represents advanced refractory heart failure, requiring specialized therapies such as LVAD or transplantation. Importantly, progression through these stages is generally irreversible. The NYHA functional classification assesses the degree of physical limitation caused by heart failure symptoms. Class 1 patients have no limitation of activity, while Class 2 patients experience mild symptoms with ordinary activity. Class 3 reflects marked limitation with minimal exertion, and Class 4 patients have symptoms even at rest. Unlike ACC-HA staging, NYHA class may improve or worsen over time, depending on treatment response.
The clinical manifestations of heart failure result primarily from congestion and reduced cardiac output. Common symptoms include dyspnea, orthopnea, paroxysmal nocturnal dyspnea, fatigue, and reduced exercise tolerance. Fluid retention may also cause rapid weight gain. On physical examination, pulmonary crackles, peripheral edema, elevated jugular venous pressure, and an S3 gallop are classic findings. Right-sided failure may additionally cause hepatomegaly and abdominal congestion.
Heart failure patients are often categorized according to congestion and perfusion status. Congested, or wet, patients exhibit pulmonary edema, peripheral edema, elevated JVP, and hepatic congestion due to increased filling pressures. Hypoperfused, or cold, patients demonstrate fatigue, cold extremities, reduced urine output, and altered mental status due to inadequate cardiac output. The most common profile is warm and wet, whereas cold and wet patients have the worst prognosis. The diagnosis of heart failure combines clinical evaluation with laboratory and imaging studies. BNP, or NT-proBNP levels, help assess ventricular wall stress, while renal function and electrolytes guide therapy and monitoring. ECG may identify ischemia, arrhythmias, or ventricular hypertrophy. Chest radiography can reveal pulmonary congestion and cardiomegaly. However, echocardiography remains the cornerstone diagnostic tool because it evaluates ejection fraction, chamber structure, valvular disease, and wall motion abnormalities.
BNP and NT-proBNP are biomarkers released in response to ventricular wall stress and elevated filling pressures. Elevated levels support the diagnosis of heart failure, particularly in patients presenting with dyspnea. However, these biomarkers may also rise in acute coronary syndrome, pulmonary hypertension, or renal dysfunction. Clinically, low BNP levels are especially valuable because they make heart failure unlikely.
Higher values are also associated with worse prognosis and increased mortality risk.
Echocardiography is considered the gold standard imaging modality in heart failure evaluation. It provides detailed assessment of left ventricular ejection fraction, wall motion abnormalities, chamber size, hypertrophy, and valvular disease. Most importantly, echocardiography classifies patients into HFref, HFMRref, or HFpEF categories, which directly guide evidence-based treatment selection and long-term management strategies. Modern HFref management is centered around 4 foundational disease-modifying therapies. These include ARNI, or ACE inhibitor or ARB therapy for RAS inhibition, evidence-based beta blockers to reduce sympathetic activation, mineralocorticoid receptor antagonists for aldosterone blockade, and SGLT2 inhibitors for cardiorenal protection. Together, these therapies reduce mortality, decrease hospitalization, improve symptoms, and slow ventricular remodeling.
Current heart failure management emphasizes early initiation of all 4 foundational therapies, rather than waiting for sequential titration over many months. Evidence demonstrates that early quadruple therapy rapidly improves symptoms, reduces hospitalization risk, and provides substantial mortality benefit. The modern approach is therefore summarized as start low, start all early, then titrate. Delayed initiation may result in missed survival benefits.
ACE inhibitors and ARBs improve outcomes in HFref by suppressing the RAS pathway, thereby reducing afterload, fluid retention, and ventricular remodeling. ARNIs, specifically sacubitril/valsartan, provide dual neurohormonal modulation. Sacubitril inhibits neprilysin, increasing beneficial natriuretic peptides, while valsartan blocks angiotensin II receptors. Compared with ACE inhibitors alone, ARNIs have demonstrated superior reductions in mortality and hospitalization. Evidence-based beta blockers in heart failure include carvedilol, metoprolol succinate, and bisoprolol. These agents reduce chronic sympathetic overactivation, lower arrhythmia risk, and promote reverse remodeling. Importantly, beta blockers should be initiated only when patients are clinically stable and euvolemic, because starting therapy during acute decompensation may worsen hemodynamics.
Mineralocorticoid receptor antagonists, such as spironolactone and eplerenone, block aldosterone-mediated sodium retention and myocardial fibrosis. These agents significantly reduce mortality and heart failure hospitalization. However, careful monitoring of potassium levels and renal function is essential because hyperkalemia and worsening renal impairment are important risks. SGLT2 inhibitors, including dapagliflozin and empagliflozin, represent one of the most important modern advances in heart failure management. Their benefits extend beyond glucose lowering and include osmotic diuresis, reduced preload and afterload, and significant cardiorenal protection. Clinical trials have demonstrated reduced hospitalization and mortality in both HFrEF and HFpEF, regardless of diabetes status. Unlike the 4 foundational therapies, diuretics primarily provide symptomatic relief rather than mortality benefit. Loop diuretics, such as furosemide and torsemide, reduce preload and rapidly relieve congestion. They are especially important in patients with pulmonary edema, peripheral edema, or acute decompensated heart failure. This combination provides balanced vasodilation through complementary mechanisms. Hydralazine primarily causes arterial dilation and reduces afterload, while nitrates predominantly reduce preload through venodilation. This therapy is especially useful in patients intolerant to ACE inhibitors or ARBs,
and has demonstrated survival benefit as add-on therapy in selected African American patients.
Ivabradine selectively inhibits the IF current in the sinoatrial node, lowering heart rate without affecting myocardial contractility. It is indicated for symptomatic HF-ref patients in sinus rhythm who remain tachycardic despite maximally tolerated beta blocker therapy. Its primary benefit is reduction in heart failure hospitalization. Vericiguat is a soluble guanylate cyclase stimulator that enhances the nitric oxide CGMP signaling pathway. It is primarily used in high-risk chronic HF-ref patients who recently experienced decompensation despite guideline-directed therapy. Clinical data show modest reduction in hospitalization risk. Digoxin inhibits the sodium-potassium ATPase pump, increasing intracellular calcium and improving myocardial contractility. It also increases vagal tone, helping control ventricular rate in atrial fibrillation. Although digoxin may improve symptoms and reduce hospitalization, it does not improve survival and carries a narrow therapeutic index with significant toxicity risk. The core strategy in HFrEF management is early initiation of the 4 foundational therapies: ARNI or ACE inhibitor or ARB, beta blocker, MRA, and SGLT2 inhibitor. Additional therapies, such as diuretics, ivabradine, hydralazine, or vericiguat, may be added based on patient-specific needs. Ongoing titration and monitoring are essential for long-term optimization. HF-MRF was previously considered a gray zone with limited therapeutic evidence. However, newer studies suggest that many patients benefit from therapies traditionally used in HF-RF, particularly SGLT2 inhibitors. Selected patients may also benefit from ACE inhibitors, ARBs, ARNIs, or beta blockers, especially when symptoms are present. HFpEF is characterized primarily by impaired ventricular relaxation and increased ventricular stiffness. It is strongly associated with systemic inflammation and multiple comorbidities, such as hypertension, obesity, diabetes, and atrial fibrillation. Unlike HFrEF, no single therapy fully reverses disease progression, but SGLT2 inhibitors have emerged as an important evidence-based treatment. Management also focuses heavily on congestion relief and aggressive comorbidity control. Management of HFpEF requires comprehensive treatment of associated comorbidities. Strict blood pressure control is essential. Diabetes management should prioritize SGLT2 inhibitors. Obesity should be addressed through weight reduction, and atrial fibrillation requires careful rate or rhythm control. Renal protection and treatment of iron deficiency are also increasingly recognized as important components of care. Management of HFpEF requires comprehensive treatment of associated comorbidities. Strict blood pressure control is essential. Diabetes management should prioritize SGLT2 inhibitors. Obesity should be addressed through weight reduction, and atrial fibrillation requires careful rate or rhythm control. Renal protection and treatment of iron deficiency are also increasingly recognized as important components of care. Acute heart failure patients are categorized according to perfusion and congestion status. Warm and wet patients are congested but adequately perfused and represent the most common presentation. Cold and wet patients have both congestion and poor perfusion, carrying the highest mortality risk. Warm and dry patients are stable, while cold and dry patients have low output states without significant congestion. These profiles help guide therapeutic decisions. Intravenous loop diuretics are first-line therapy for acute congestive heart failure. Agents such as furosemide rapidly reduce intravascular volume and relieve pulmonary congestion. During treatment, clinicians must carefully monitor renal function, electrolytes, urine output, and symptomatic response.
In acute hypertensive heart failure or pulmonary edema, intravenous vasodilators, such as nitroglycerin or nitroprusside, can rapidly reduce preload and afterload. This decreases cardiac filling pressures and improves pulmonary congestion. Blood pressure monitoring is essential because excessive vasodilation may cause hypotension.
Inotropes, such as dobutamine and milrinone, increase myocardial contractility and improve cardiac output. They are reserved primarily for cardiogenic shock or severe hypoperfusion. Although they may temporarily stabilize hemodynamics, inotropes increase arrhythmia risk and may worsen long-term mortality. Cardiogenic shock represents severe failure of cardiac output, resulting in hypotension and end-organ hypoperfusion. Clinical manifestations include altered mental status, cold extremities, oliguria, and lactic acidosis. Management involves inotropes, vasopressors, such as norepinephrine, and consideration of mechanical circulatory support when pharmacologic therapy is insufficient. Implantable cardioverter defibrillators reduce sudden cardiac death risk in patients with severe systolic dysfunction and high arrhythmic risk. Cardiac resynchronization therapy improves ventricular synchrony in patients with conduction abnormalities such as left bundle branch block. CRT can improve ejection fraction, symptoms, and survival in appropriately selected patients. Advanced heart failure may require mechanical circulatory support, such as LVAD therapy, either as a bridge to transplant or as destination therapy. Heart transplantation remains the definitive treatment for selected patients with end-stage refractory heart failure. However, donor availability and lifelong immunosuppression remain major limitations. Iron deficiency is highly prevalent in heart failure and contributes to fatigue, exercise intolerance, and reduced quality of life. Chronic inflammation and impaired absorption are common causes. Intravenous iron therapy, particularly ferric carboxymaltose, has demonstrated improvement in functional capacity and symptom burden. Diabetes significantly increases the risk of developing heart failure and worsens cardiovascular outcomes. SGLT2 inhibitors are now considered foundational therapy because they improve both glycemic and heart failure outcomes. In contrast, certain thiazolinodiones should generally be avoided because they promote fluid retention. Chronic kidney disease and heart failure frequently coexist in a bidirectional relationship known as cardiorenal syndrome. Management is challenging because many therapies affect renal function and potassium balance. SGLT2 inhibitors and cautious RAS inhibition remain important strategies, but careful monitoring is essential. Atrial fibrillation is a common comorbidity in heart failure and is associated with worse symptoms and outcomes. Management includes rate control using beta blockers or digoxin, rhythm control in selected patients, and anticoagulation when indicated to reduce thromboembolic risk. The modern HREF treatment algorithm emphasizes rapid initiation of the 4 foundational therapies, followed by ongoing titration to target doses. Diuretics are added for congestion, while therapies such as ivabradine, hydralazine, or vericiguat are reserved for selected patients. Continuous monitoring of blood pressure, renal function, potassium, and symptoms is essential. In acute heart failure, Clinicians first assess congestion and perfusion status using the warm, cold, and wet, dry framework. Treatment is then guided by hemodynamic profile. Diuretics relieve congestion, vasodilators improve elevated filling pressures, and inotropes support patients in shock. Escalation to advanced support is necessary when hypotension or organ failure persists. Several major advances have transformed modern heart failure management. SGLT2 inhibitors are now considered foundational therapy. Early quadruple therapy is preferred over delayed sequential initiation. ARNIs are used earlier in treatment pathways, and HFpEF now has evidence-based therapeutic options. Additionally, greater emphasis is placed on phenotyping, hemodynamic assessment, and treatment of comorbidities such as iron deficiency.
Heart failure is a progressive neurohormonal syndrome requiring early and comprehensive treatment. Modern guideline-directed therapy significantly improves survival, reduces hospitalization, and slows disease progression. The 4 core disease-modifying therapies are ARNIs, evidence-based beta blockers, MRAs, and SGLT2 inhibitors. Clinical pharmacists play a critical role in therapy optimization, medication safety, patient education, adherence monitoring, and multidisciplinary heart failure care.